Welcome to the Hospital Medicine Unplugged podcast. Today we're diving into a really critical topic, septic arthritis.
Yeah, and our focus is pretty specific here. We want to really dissect the urgent diagnosis, the evidence-based management, but specifically in the context of our hospitalized patients. It's often trickier there.
Absolutely. And that word urgent, I mean, we can't stress that enough, can we? Septic arthritis is a genuine medical emergency where, honestly, time is tissue. Time is cartilage.
It really is. The progression can be so rapid. You're looking at irreversible joint damage, permanent disability, and even systemic complications if you don't act fast.
And the mortality figures, when you look at hospitalized patients, they're quite sobering. We're talking ranges from, 7% up to maybe 17.5%?
That's right, which puts it right up there with some really serious conditions that we manage. It underscores why focusing on the inpatient setting is so crucial.
Because these are the patients, the ones on our wards, often with multiple comorbidities, who are carrying the highest risk.
Exactly. They have that inherent risk load. So identifying those predisposing factors, that really has to be step one when you're triaging or evaluating these patients.
Okay, so let's break that down. Thinking about the patients we see every day in the hospital, what specific characteristics, what comorbidities really elevate that risk profile for septic arthritis?
Well, the list is pretty extensive, reflecting the kind of patients we often manage. Advanced age is definitely a big one, especially folks over 80. Their immune response might just be slower, blunted.
And that often overlaps with other conditions too, right?
It does. You see a lot of overlap with metabolic conditions, diabetes mellitus being a huge one. Diabetes creates this environment, poor immunity, but also neuropathy that can sometimes mask those early joint symptoms.
That's a good point. And what about the joint itself? It's not just systemic factors, is it? The state of the joint matter.
Oh, absolutely. Any pre-existing damage or, importantly, any hardware, that's a major vulnerability. So a history of inflammatory arthritis, like rheumatoid arthritis, or even just significant osteoarthritis.
And prosthetic joints.
Prosthetic joints, definitely. Hip or knee replacements are critical potential entry points. And even recent procedures, like a joint surgery or maybe just an arthroscopy, that can introduce bacteria.
Right. Creates a focus. And linking back to the systemic side, what about immunosuppression? That comes up a lot.
Yes, any kind of immunosuppression, whether it's from diseases like HIV or malignancy, or very commonly in our patients, iatrogenic causes.
Like the drugs we give them.
Exactly. Immunosuppressive drugs, biologics for rheumatologic conditions, high-dose steroids, these dramatically increase susceptibility. And then you have chronic organ failure.
Such as?
Chronic liver disease, chronic renal disease, and critically important, patients on hemodialysis. Those dialysis access points are recurrent risks for bacteremia.
It feels like the list keeps growing. The sources even mention things like chronic heart failure or hypertension as additional risk factors. Why is that? They aren't directly immunosuppressive?
That's true. They're not direct immune suppressors in the same way. But they often correlate strongly with a state of chronic inflammation, frequent hospital exposures.
More chances for bugs to get in.
Precisely. And maybe preceding bacteremia, perhaps from a UTI that led to the admission in the first place, or even an active skin infection somewhere else on the body. Seems minor, but it can be the source via hematogenous spread.
So when you see these factors starting to stack up in a patient,
your index of suspicion just has to shoot way up immediately.
Okay, let's shift gears a bit to the pathophysiology. You mentioned hematogenous seeding being primary. How does the bacteria actually get into the joint and cause such rapid destruction?
So most commonly, it travels through the bloodstream, the hematogenous route, and it settles in the synovial membrane, which is really richly vascularized.
But it's not the only way, right?
No, definitely not. You also see direct inoculation. Think penetrating trauma, maybe a joint injection that wasn't perfectly sterile, surgery obviously, and then there's contiguous spread and infection nearby, like cellulitis or osteomyelitis, just spreading into the joint space.
But what is it about the joint structure that makes it so susceptible to being destroyed so quickly?
This is key. It comes down to the synovial membrane itself. Unlike a lot of other tissues, it lacks a basement membrane.
Okay, so it's less of a barrier.
Exactly. It's almost like an open door for pathogens to get into the synovial fluid fast. Once they're in there, they multiply, sure, but the real damage comes from the intense inflammatory response they trigger.
The body's own response causing damage.
Pretty much. You get this flood of neutrophils, polymorphin nuclear leukocytes. And these cells release really destructive enzymes, things like metalloproteinases, elastases. These enzymes just chew through the cartilage matrix, the proteoglycans.
And this happens quickly.
Incredibly quickly. We're talking hours to maybe a few days. If that purulent effusion, that pus, isn't removed, you get irreversible cartilage damage and long-term functional loss. It really highlights why speed is everything.
Okay. Underscores the need for swift action. Let's talk microbiology then. Knowing the usual suspects is critical for picking empiric antibiotics. In adults, who's the main culprit?
Overwhelmingly, the dominant pathogen in adults is staph or aureus. It accounts for the lion's share of cases.
And we need to think about both types.
Absolutely. Both methicillin-sensitive, MSSA, and methicillin-resistant, MRSA. Always have to consider both.
And focusing on our hospitalized patients, how significant is MRSA in septic arthritis?
It's hugely significant. The data, the sources are very clear. MRSA infections mean higher morbidity, longer hospital stays, and definitely increased mortality.
And hospitalized patients are more likely to have it?
They are, especially those with prior healthcare contact. Maybe they're on dialysis or residents of nursing facilities. The carriage rates are just higher. So if your patient has any of those high risk factors we talked about,
you need to cover MRSA empirically.
You have to, until you get cultures back proving otherwise. MRSA coverage is pretty much mandatory in those high-risk folks.
Okay. Beyond staph or anoresius, what other gram-positive cocci should be on our radar?
Well, you certainly see various strep species. They can sometimes be a bit less destructive than staph, but still need prompt treatment. Group B strep comes up, especially in diabetics or the elderly.
Right.
And coagulus negative staph. Now, often we think of coag-neg staph as a contaminant.
Right, from the skin during the tap.
Yeah, but in the context of a prosthetic joint or any kind of hardware, you absolutely cannot dismiss it. It has to be taken seriously there.
Good point. What about gram-negatives? Less common overall, but crucial in certain groups. Things like E. coli or Pseudomonas aeruginosa.
Exactly. Gram-negative coverage becomes really important when you're dealing with immunocompromised patients or people with recent significant healthcare exposures, maybe a central line, complex surgery.
Or specific comorbidities.
Yes, like chronic kidney disease or severe diabetes.
Yeah.
And Pseudomonas. That's a particular worry in healthcare-associated infections or sometimes in intravenous drug users.
Okay. And just to be complete, even though we're focused on adults, sometimes we get consulted on younger patients, or maybe internal medicine covers PEDS transitions. Any key pediatric bug to mention?
Yeah, it's worth knowing Kingella kingae. It's a leading cause in kids under 4. The tricky part is catching it.
Why is that?
It's fastidious, doesn't grow easily on standard cultures, so you often need specialized molecular diagnostics like 16S rRNA PCR or sequencing to actually identify it. Standard culture might just come back negative.
Good to keep in mind for those occasional consults. All right, that sets the microbial stage. Let's pivot now to the diagnostic workup. This needs to happen fast, right? As soon as suspicion arises.
Absolutely. The clock is ticking. The classic sort of hallmark presentation is that acute, usually atraumatic, single joint monoarticular pain, swelling, redness, warmth.
But what's the most sensitive physical exam finding we should look for?
The absolute key finding, the one that should really raise alarm bells, is marked limitation in both active and passive range of motion. If gently trying to move that joint causes excruciating pain, if the patient just refuses to let you move it.
Septic arthritis is top of the differential.
Until proven otherwise, yes.
But you mentioned earlier, sometimes the presentation is subtle. This is where it gets tricky for us as hospitalists, especially with those high-risk patients. How reliable are things like fever or white count?
Not nearly as reliable as we'd like, especially in that high-risk group. The literature shows fever is only present maybe half the time.
Only half? Wow.
Yeah. So an elderly patient, someone on chronic steroids, maybe an ESRD patient on dialysis, they might present very subtly. Maybe just a new decline in mobility or confusion with not much obvious joint swelling.
So the absence of fever doesn't rule it out?
Absolutely not. Yeah. And neither does a normal peripheral white blood cell count. We just can't rely on those systemic markers alone.
Okay, so the non-specific labs, CRP, ESR, peripheral WBC, they're common, often elevated, but they lack specificity. They're adjuncts. What's the single most critical diagnostic step then?
Arthrocentesis, joint aspiration. It is the gold standard. It's mandatory for definitive diagnosis.
And the timing is critical here.
Crucial. It has to be done immediately. And, importantly, it should ideally be done before starting empiric antibiotics.
Unless.
The only exception is if the patient is clearly septic, hemodynamically unstable, then, okay, stabilize, get blood cultures, give antibiotics,
Right.
but in almost every other case, get the synovial fluid first. Giving antibiotics beforehand just tanks your culture yield and makes everything harder.
Right, so you get the tap, you send the fluid. What are we looking for specifically in that synovial fluid analysis?
Okay, 3 key things you absolutely have to send: cell count with differential, gram stain, and aerobic and anaerobic cultures.
And what are the typical diagnostic thresholds we learned?
The classic teaching is a synovial fluid white blood cell count over 50,000 per cubic millimeter, and importantly, a high percentage of neutrophils, specifically polymorphic nuclear cells, or PMNs, greater than 90%. That high PMN percentage is often even more indicative than the total white count itself.
But that 50,000 threshold, that can overlap with other things, right? Like a really bad gout flare.
Exactly. That's probably the biggest diagnostic challenge we face. A severe crystal arthritis flare, like gout or pseudogout, can easily push the white count over 50,000, sometimes even over 100,000.
So how do we tell the difference when the count is sky high?
Okay, couple of things. First, you must look for crystals under polarized microscopy, but finding crystals doesn't automatically rule out infection. You can have both at pseudoseptic arthritis.
Right, the crystals were there first, then it got infected.
Precisely. Second, some other fluid markers can help differentiate.
Yeah.
Synovial fluid glucose tends to be significantly lower than serum glucose in septic arthritis because the bacteria are consuming it. And synovial fluid lactate can be helpful too. Levels above, say, 10 millimoles per liter are highly suggestive of bacterial infection. In gout, lactate is usually much lower.
But we shouldn't get too fixated on that 50,000 number.
No, definitely not. Lower counts, even in the 10,000 to 20,000 range, absolutely do not exclude infection, particularly in those immunocompromised patients, or if antibiotics were given early. Clinical suspicion has to remain high.
And to give the lab the best shot at growing something, any specific tips on handling the fluid?
Yes, this is important. The IDSA, Infectious Diseases Society of America, and the ASM, American Society for Microbiology, both strongly recommend inoculating the synovial fluid directly into blood culture bottles.
Instead of the usual sterile container.
Right. The blood culture bottles provide an optimized growth medium and can sometimes recover organisms even if there was some antibiotic effect. It just maximizes your yield.
Makes sense. Now, what about other tools like imaging or molecular tests? They shouldn't delay the tap, but where do they fit in?
Correct. They're adjunctive. Imaging really serves 2 main purposes: guiding the aspiration itself and looking for complications.
Which modality is best for guidance?
Ultrasound. It's fantastic, it's quick, you can do it at the bedside, and it's great for detecting effusions, especially in deeper joints like the hip or shoulder where landmarking can be tough. And it's invaluable for guiding the needle accurately, particularly if you get a dry tap initially.
And for looking for complications like osteomyelitis.
That's where MRI comes in. It's the most sensitive for picking up early changes in the bone or surrounding soft tissues. So you'd order an MRI if you suspect concomitant osteomyelitis. Maybe the symptoms have been going on longer, or the patient isn't responding as expected, or if you're worried about a deeper abscess that might need surgical drainage.
But the key caveat with imaging:
it cannot tell you definitively if the fluid is infected or just inflamed. It can show an effusion, it can show inflammation, but it can't distinguish pus from sterile inflammatory fluid. Only the aspirate can do that.
Got it. Aspiration remains king. What about molecular diagnostics? These are becoming more available.
And we really should be using them more. The guidelines, again from IDSA and ASM, recommend molecular testing things like multiplex PCR panels or 16S RNA gene sequencing in a couple of key situations.
Like when?
First, when your cultures are negative, but your clinical suspicion for infection is still really high. Molecular tests can sometimes pick up bacterial DNA even when the bugs won't grow. Second, they're crucial for detecting those fastidious organisms we mentioned earlier, like Shigella kingae in kids, or maybe Borrelia burgdorferi if you're thinking Lyme arthritis. Standard cultures can easily miss these.
So leverage the technology when the standard approach isn't giving answers. Okay, let's move into management. The diagnosis is suspected or confirmed, the clock is ticking. What are the immediate priorities?
Right, first things first, rapid assessment of hemodynamic status. Are there signs of sepsis, hypotension, tachycardia, tachypnea? Need to monitor closely. And prompt pain control is essential, both for the patient's comfort and, frankly, to make subsequent procedures tolerable.
And antibiotics.
If the patient is unstable, showing clear signs of sepsis, then yes, empiric antibiotics should be started immediately after blood cultures are drawn, even before you have the synovial fluid results. Life support comes first.
But assuming the patient is stable, what's the absolute cornerstone of management, regardless of anything else?
Source control. You have to get the purulent material out of the joint. It's non-negotiable.
Why is that so critical? Can't antibiotics just handle it?
Not effectively, no. Antibiotics have poor penetration into thick pus and fibrin clots, and leaving that inflammatory soup in the joint just guarantees ongoing cartilage destruction from those enzymes we talked about. It leads to long-term damage.
So how do we achieve source control? What are the options?
The goal is early and complete drainage to get that pressure down. The main methods are repeated needle aspiration, arthrocentesis, sometimes guided by ultrasound, or surgical drainage, either arthroscopic washout or an open debridement, arthrotomy.
How do you decide between needle aspiration and surgery?
Surgery is generally reserved for a few situations. Joints that are anatomically difficult to aspirate repeatedly, like the hip. If the pus is really thick or loculated, meaning it's walled off in pockets. If the patient isn't improving clinically after, say, 48 hours of nasal drainage and antibiotics. Or if there are complications like associated osteomyelitis that need debridement anyway.
Okay, now let's talk empiric antibiotics, assuming we've sent the fluid but don't have results yet. How do we choose, keeping our hospitalized, often high-risk population in mind?
You tailor it based on a few things. Local resistance patterns, if the patient is known to be colonized with something like MRSA, and their individual risk factors. For a relatively straightforward native joint infection in an otherwise lower-risk adult, something like amoxicillin clavionate or maybe a second-gen cephalosporin like cefuroxime might be reasonable to cover MSSA and common strep.
But that feels insufficient for many inpatients. We have to think about MRSA.
Absolutely. That's the key adjustment for the hospitalized population. Given the risks we discussed, known carriage, recent healthcare exposure, nursing home resident, immunocompromise, you really need to add vancomycin empirically for MRSA coverage right up front.
And starting vancomycin means thinking about dosing and monitoring right away.
Immediately. Dose based on weight and renal function, and plan for trough-level monitoring to make sure you're therapeutic, but avoiding toxicity, especially nephrotoxicity.
What if the gram stain comes back quickly and gives us a clue? How does that refine the choice?
Oh, an early gram stain result is incredibly helpful. If you see gram-positive cocci, that strongly supports keeping the vancomycin going, or maybe considering daptomycin if there are concerns about vancomycin toxicity or renal failure.
And gram-negatives.
If it shows gram-negative diplococci, you'd lean towards high-dose ceftriaxone, thinking Neisseria. If you see gram-negative rods, though, you need broader coverage. That often means an anti-pseudomonal beta-lactam like cefepime or ceftazidime, especially if the patient is high risk.
And in the sickest, most immunocompromised patients.
In really sick, immunocompromised patients, diabetics, maybe someone with chronic liver disease, you might even need very broad spectrum coverage initially, like piperacillin tazobactam, to cover potential polymicrobial infections or highly resistant gram-negatives.
Okay, so that's empiric. Once the bug is identified and susceptibilities are back, we narrow things down. What's the typical duration of therapy for, say, an uncomplicated native joint infection?
For straightforward native joint septic arthritis, the total duration, combining IV and oral therapy, is usually in the range of 2 to 4 weeks.
2 to 4 weeks. Seems like a range. How do we decide?
Well, for Staph aureus, most guidelines and experts still lean towards a full 4 weeks, just to be safe. However, there's emerging evidence, particularly for smaller joints like the wrist or hand, especially if they had prompt and complete surgical washout, that a shorter course, maybe even just 2 weeks total, could be sufficient for some uncomplicated cases.
But that requires careful selection and follow-up.
Absolutely. You need to be confident about the source control and monitor them very closely if you're going for a shorter duration.
When do we definitely need to treat for longer?
The duration gets extended significantly if it's a complicated infection. The main reason is concomitant osteomyelitis if the infection has spread into the adjacent bone. That requires a longer course, typically at least 6 weeks total, to ensure eradication from the bone.
And the switch from IV to oral therapy, when is that appropriate?
You can usually transition to oral antibiotics once the patient is clearly improving clinically, less pain, better function, a febrile for maybe 48 hours, and you have the pathogen identified with known susceptibilities. And there's a good oral option with high bioavailability. For most common bugs causing uncomplicated septic arthritis, oral step-down therapy is generally considered non-inferior once the patient is stable and improving.
Okay, that covers the general approach. Let's spend some time on special populations or situations that often pose challenges, What about gonococcal arthritis? It presents differently, right?
Yeah, it's quite distinct. Usually affects younger, sexually active adults, often women. The presentation is often less acutely destructive to the joint itself and frequently involves multiple joints polyarthralgia rather than just one.
And the classic triad.
Right, you look for migratory polyarthralgia, where the pain moves from joint to joint, tenosynovitis, which is inflammation of the tendon sheaths, often in the wrists or ankles, and these characteristic skin lesions, usually few, small, painless pustules, often on the extremities.
Diagnosing it can be tricky because the bug, Neisseria gonorrhea, doesn't always grow well from the joint fluid itself.
Exactly. Culture yield from synovial fluid is often low, so diagnosis relies heavily on getting cultures or nucleic acid amplification tests from other sites. Urethra, cervix, rectum, pharynx, and urine is crucial.
And the treatment is different, too.
Yes. Empiric treatment typically starts with ceftriaxone, usually 1 gram IV or IM daily. And unlike other bacterial septic arthritis, joint drainage is often not needed unless there's a very large purulent effusion or the patient isn't responding. The response to antibiotics is usually quite rapid.
And the duration is shorter.
Much shorter. Patients usually step down to an oral agent, like cefixime or maybe a fluoroquinolone, depending on local resistance, to complete just a 7-day total course. The prognosis is generally excellent. Permanent joint damage is rare.
But crucial public health aspect here.
Absolutely. You have to screen for other STIs, and it's essential to ensure treatment of any recent sexual partners.
Okay, moving on to another really complex area, prosthetic joint infection, PJI. This is a huge issue for hospitalists.
Huge, and it requires a totally different mindset, both diagnostically and therapeutically. The big difference is that PJIs are often caused by less virulent organisms like coagulus-negative staph, and they frequently present more chronically or subacutely.
Which means the inflammatory response might be lower.
Exactly. You don't typically see those sky-high synovial fluid white counts like in native joint septic arthritis.
So that 50,000 cutoff we discussed is useless here.
Completely irrelevant for PJI. The diagnostic thresholds are much, much lower. You're looking for a synovial fluid white count maybe greater than just 1,100 per cubic millimeter, or a neutrophil percentage over 64%. Using the native joint criteria will lead you to miss many chronic PJIs.
And management always involves surgery.
Pretty much always requires a multidisciplinary approach involving orthopedics, infectious diseases, and us. Surgical intervention is almost always necessary. For acute PJIs, maybe within a month of surgery or an acute hematogenous seeding event, sometimes they can attempt DARE. Debridement, antibiotics, and implant retention. Basically, wash out the joint aggressively, change exchangeable parts if possible, and give long-term antibiotics. But for chronic infections, or if DARE fails, the standard becomes revision surgery, either a 1-stage or, more commonly, a 2-stage revision, where they take everything out, put in a temporary spacer with antibiotics, treat with IV antibiotics for weeks, and then go back in later to put in a new prosthesis. It's a major undertaking.
And the antibiotic courses are much longer, often 6 to 12 weeks. Why so long, and why does rifampin often get added for staph PJI?
The duration is long because PJI is fundamentally a biofilm infection. The bacteria form this protective slime layer on the implant surface, which makes it really hard for antibiotics to penetrate and kill them.
So you need prolonged therapy.
Yes, and often combination therapy.
Right.
Rifampin is frequently added for staph PJIs because it has good activity against bacteria within biofilms. It penetrates that matrix relatively well. It's usually used in combination with another agent like a fluoroquinolone or maybe oxacillin, depending on susceptibility.
But rifampin has issues.
Big time. Lots of drug interactions because it's a potent CYP450 enzyme inducer.
Yeah.
You have to be really careful managing other medications when a patient is on rifampin.
Okay. Let's touch on a couple more high-risk host factors. Severely immunocompromised patients or intravenous drug users, IVDUs. What are the key considerations there?
These patients are just exponentially more complex. They're at much higher risk for unusual or resistant pathogens. Think MRSA, definitely, but also Pseudomonas, other resistant gram-negatives, even fungal infections like Candida.
And they might present differently.
Yeah, they're also more likely to have polyarticular involvement infection in multiple joints at once. So your initial empiric antibiotic coverage has to be much broader from the get-go. You can't just use standard regimens. You might need multiple agents covering MRSA, Pseudomonas, maybe even fungi initially. And source control needs to be very aggressive.
One last tricky scenario. The patient on anticoagulation. Very common in the hospital. How do we manage the need for urgent aspiration or drainage?
Yeah, this requires careful balancing. Urgent drainage is needed, but these are invasive procedures with bleeding risk. A diagnostic joint aspiration isn't strictly contraindicated if someone's therapeutically anticoagulated, but you have to be cautious, use a small needle, apply pressure. The risk of hemarthrosis is real.
What about surgical drainage?
For surgical drainage, you almost always need to optimize their coagulation status first. That might mean holding the anticoagulant, potentially reversing it depending on the urgency and the agent. This absolutely requires discussion between orthopedics, hematology potentially, and the primary team to weigh the risk of delaying source control versus the risk of bleeding.
Makes sense. A real team effort there. Okay, we've covered diagnosis and management in detail. Let's talk about monitoring the response, potential complications, and prognosis. Once treatment is started, how do we know if it's working?
You need frequent clinical reassessment. It's not just about systemic signs like fever. You have to examine the joint itself. Is the pain improving? Is the swelling going down? Critically, is the range of motion getting better? If that range of motion isn't improving within, say, 48 to 72 hours, something's wrong.
And what about labs? What should we be tracking?
Serial inflammatory markers are key, CRP and ESR. CRP is generally more useful acutely because it changes faster, has a shorter half-life. You want to see that CRP coming down steadily.
Yeah.
A rapid decline usually correlates well with a good clinical response.
So if the CRP isn't dropping or plateaus?
That's a red flag. It suggests either the antibiotics aren't covering the bug, or more commonly, there's inadequate source control. Maybe the pus is loculated, or the initial drainage wasn't complete.
So failure to improve clinically or biochemically within about 48 hours means we need to rethink things.
Absolutely. You need to consider repeating the synovial fluid analysis, maybe ultrasound guided this time, to check the cell count again and reculture. And you need to think about advanced imaging, usually an MRI, to look specifically for complications like an abscess that needs drainage or underlying osteomyelitis that wasn't initially apparent.
What are the key things that need to be achieved before we can safely discharge a patient?
Several things. They need to be afebrile. The joint function needs to be significantly improved. The inflammatory markers should be trending down nicely. Source control needs to be complete. Either the joint is dry from aspirations or they've had successful surgical drainage. And they need to be stable enough to transition to and tolerate oral antibiotics.
Despite our best efforts, though, septic arthritis can leave patients with significant long-term problems.
Devastatingly so. The morbidity is high. Irreversible joint destruction leading to chronic pain. Significantly reduced mobility, sometimes requiring joint replacement down the line. And osteomyelitis can become a chronic issue. Plus, the systemic risks during the acute phase, sepsis, bacteremia, organ failure, contribute to that high mortality we mentioned.
Those mortality figures, again, 7 to 17.5% in hospital, but potentially much higher long-term for high-risk groups.
Yeah, for patients with PJI or those with severe comorbidities, some studies show 5-year mortality rates approaching 28%. It's a very serious infection.
What factors consistently predict a poor outcome?
Delays are a big one. Delay in diagnosis, delay in starting appropriate treatment, and especially delay in achieving adequate source control. Beyond that, it's the host factors. Advanced age, underlying comorbidities like diabetes, kidney disease, liver disease, and any significant immunosuppression. These things impair the body's ability to fight the infection and heal the damage.
Okay, this has been a really thorough look at a condition that demands sharp skills from hospitalists. If we were to boil it down, what are the absolute core pillars for managing septic arthritis effectively in the hospital?
I'd say 3 non-negotiable time-sensitive pillars. First, rapid diagnosis. Get that joint fluid immediately via aspiration, send it for the right tests, and use blood culture bottles. Second, mandatory and aggressive source control. Drain that pus, whether by needle or surgery, often needing quick orthopedic input. And third, timely, tailored antibiotics.
And the key point for empiric choice in our hospitalized patients.
Recognize the high-risk host. That means covering for MRSA and potentially resistant gram-negatives right from the start in many of these patients until you have regenerative culture data.
As we wrap up, it's clear we focus intensely on the acute management, but thinking longer term, once the patient leaves the hospital, is there an area where the evidence or guidelines are maybe less clear?
That's a great point. One area where there's a surprising lack of strong evidence or consensus is around the optimal strategy for long-term follow-up, especially for complicated cases. How often should we be seeing these patients back? What specific clinical, lab, or even imaging assessments should we be doing, and for how long?
So we get them through the acute phase, but ensuring full recovery is less defined.
Exactly. It leads to a question for everyone listening. How rigorously are you tracking these patients, particularly the high-risk ones, after discharge? Are we just relying on them reporting symptoms? Or are we proactively monitoring things like CRP or ESR trends, assessing joint function over months to really confirm complete resolution and try to prevent those long-term debilitating sequelae that can really impair quality of life long after the infection itself is gone? Something to think about in our practice.